stated, I don't have my camera on, but if I did, you would see that I'm wearing my Warriors t-shirt, and I'm a big Warriors fan, and so I'm recording the game, and so no one is to say anything about the status of any basketball games while we're talking. Now, this opening slide is kind of smart, but we did a presentation last week, and we had a wonderful guy, Colin LeClaire, from the Monarch ACO that Optum owns. And, he was sort of predicting this demise of fee-for-service, and I don't know if that's going to happen. But when you think about it, it's a pretty old model. That's the best date I could come up with for the creation of that Blue Cross model. And I think we're going to have fee-for-service for a long time to come, but it's not your father's fee-for-service, and that's what we're going to talk about. So CMS. Everybody kind of knows who CMS is or HIP is, but I always like to make sure people know what we're trying to do, which is important. We're about 5,000 people spread around the country, and probably 60 or 70,000 people at state agencies and contractors and so forth that do the work that supports our programs. What we're trying to do is first make healthcare more affordable by making it better. From Dr. Berwick's time at the agency, we learned very clearly that if care is better, the spend is less because you do things just once and you're doing the right thing, so you don't waste time doing the wrong thing. Prevention and population health is not something that we paid attention to so much when I started back in the late 1970s, but now we fully understand that it's not good enough to be an insurance company and pay bills. We have an obligation to the taxpayers that fund us and the beneficiaries to use our program as effectively as possible to improve healthcare across the board that benefits the entire population. And of course, a really big piece of that is making sure that people take advantage of the appropriate preventive and screening tools. Our third major goal, expanded healthcare coverage. Obviously, since the passage of the ACA, we think there's about 14 million people that are under health insurance coverage that weren't at that time. We think that's a great thing because that's our job. We're happy that we're doing it. We also know that there's a great deal more to be done, and we're in the process of planning this year's fall enrollment season. And finally, our goal is to have enterprise excellence for us, where our workforce develops and works together and is innovative. And I can tell you that this is happening more than I've ever seen before. We're just incredibly fortunate to have Dr. Berwick and now Andy Slavitt, just really great people that really care about people. And that's really, really important. So I'm very excited about that. So all this change, what we're trying to do is move away from where the United States has been in the past with a program that's really built around the providers of care, the producers, if you will, because that system isn't going to last forever, and it results in a lot of fragmentation. So we're going to do that by managing our payment systems, basically, because that's our lever. So the future state that we want is a world that's built around patients and what patients want, a world where practitioners, their success yields the maximum remuneration for the work they're doing, something that can last into the future that's not going to break the bank, and we want care to be more coordinated. If there's one thing that we could change, absent every other innovation you could think of, it would be just to get providers that are working on a particular patient to have the same information about that patient, to talk to that patient, talk to each other about the patient, and so forth. And we've got a bunch of things in the works that I'm going to talk about on the bottom of that slide that take us there. So this notion of using payment as a lever or a way to influence the system leads us to categorize different kinds of payments, and this is going to frame our discussion tonight. So the traditional payment, starting in 1929, was the provider, the doctor, the hospital performs a service. We look up how much the service cost should have been paid, and we pay them that amount. There's no relationship to anything other than did they do the service and was the person qualified for the service. And that's really already rarely the case, because most of our stuff is in category 2, where the payment is basically fee for service. Some component of it is tied to quality or efficiency. That's true for hospitals. That's true for doctors now. It's true around how we manage readmissions and managing conditions that are required in the hospital. I'm going to talk about that a little bit. Now, the next category, where we get a little more aggressive, is where we have a whole different way of paying, different methodology, if you will. And this is where The payment is for the result of effective management of the population that those providers see. And while individual payments may be triggered by the delivery of individual services, there's the opportunity for two-sided risk, both on the downside and the upside, if providers can do a better job. Several examples of this that we're going to talk about. And then what my friend Colin described last week as population payment nirvana. We don't know exactly what it's going to look like, but what we know is we're going to go further and further in this direction of tying remuneration, tying spending the Medicare trust funds and the other dollars that we spend to producing results in terms of people's health and people's health outcomes and evidence-based care. That's what that's going to look like. The methodology is still being developed. What I'd like you to do is really think about this as evolutionary. So you could study healthcare in the United States or Britain or anywhere else, and it wasn't like somebody came along with a grand plan. These things evolve and change over time, and sometimes we know what we're evolving toward is going to look like, but we don't know exactly all the features of it yet. That's what we, together with the states and the industry, both health insurance and providers, are all trying to do. So our secretary, Sylvia Matthews-Burwell, who is absolutely delightful, smart as a whip, but also super nice and personable, great person. I really like her. She articulated a pretty aggressive goal back in January about how we were going to move our payments across that continuum more aggressively than we had planned to previously. And I can tell you, as somebody that reads compilations of news clips every day and goes to a lot of conferences and board meetings and so forth, this has got a lot of traction out there. The providers are paying attention because they know we really mean it, and it's pretty far down the road when we get to the end of the current administration. And this is the most important thing, these are not political partisan ideas. These ideas we've been moving toward for a long time, and most of the things that I'm talking about today are really things that were in the Senate Finance portion of the bill that became the Affordable Care Act, and were created in a bipartisan manner. And what we see inside the government working with elected officials isn't what you see in campaigns on the news. We see people that really care, that have staff people that really care, that really want to work with us to make programs work for their constituents. That's a very positive thing. It's probably one of the best things I've taken away from a long career in government service, is the depth to which people really are committed to those important things. So what we're going to do is we're going to move in that direction. The way it looks on this chart, we want to get 90% of the payments we make to have a quality component by 2018, and we want half of the payments we do in that alternative kind of space where they're actually linked to quality, such as accountable care, medical homes, and so forth. So that's where we're going, and I should have said, I've got the chat open here, and I wanted to say if people have a question or a clarification, something that they don't understand, feel free to pop that up and then I'll point it out, because if you thought of something like that, it's certain that there's somebody else that thought of it and maybe felt a little shy or didn't want to say it. One of the things that's nice here, unlike a media in person, is you can say something everybody else doesn't really know who you are. You don't stand up in front of them. I find at regular conferences people will often stay behind because they want to ask something sort of privately, and that's fine. Okay, so that movement toward 2018, this little chart here breaks down where we are in some of those spaces, and we are going to get into that in a little more detail. But around accountable care, and accountable care taken broadly is where we work with a group of healthcare providers. They have to include primary care doctors, and we identify that population of Medicare patients that use their services for most of their primary care, and we make a deal with them saying, if you can meet a set of quality standards and report on those and spend less taking care of this population next year than we predict with our model, we'll share the savings with you. And if you want to go for a bigger spread on that, we have an option where you can take a risk on the downside. And that's shared savings, basically. That's the idea. The gold at the end of the rainbow is the difference between what Medicare would have spent for those patients and what it actually spent. And you share that. A portion of it goes to those doctors and hospitals, and a portion of it goes back to the taxpayers. We have a pioneer accountable care organization where they started taking risk in the beginning. They are playing at essentially the big risk table, the $50 table. We're going to talk a little bit about bundled care in a minute, how we pay for that. This is another way to get to payment for the outcomes that we're looking for. We're going to talk about advanced primary care and what we're doing there, and there's a few other models that are also working. So this is a different look at this business about linking fee-for-service payments to quality or value. So if we look at this year, the middle bar there, you can see that 7% of the payment that we make to a hospital is at risk on the downside. If they lose everything, they're only going to get 93% of what they would have paid. And for those of you that work in the hospital space, you know that Medicare is a very important payer because the people that are in Medicare are elderly or disabled. Therefore, they're people that are more likely, much more likely, to need medical care. And so that's where we're at that program, and that's for hospitals. On the doctor side, you can see we are moving into a much more aggressive space in terms of the percentage of their payments that would be attenuated for quality. Right now, we're only doing that for groups of 100 physicians or more, but we're going to be taking that groups to 10 and eventually all the way down to groups of 1. Now, I alluded to this before. After the last presidential election, the one before the last one, I should say, 08, we were about to launch a medical home project, and the incoming secretary said, let's put on the brakes and let's do this in states where the state Medicaid program and the private insurers want to join us in all offering the same set of incentives to the providers. That way, Dr. X won't have to act differently for one payment she just saw versus the next one because they're all going to be incentivized the same. And we did that in a number of places. That's working. So it's around convening people on the ground that work in healthcare. It's about accountable care, like I talked about, where we're requiring those more advanced accountable care organizations to have value-based payments in their private business. And then we're funding states to do these very interesting innovation models. One is in Maryland, where they pay hospitals the same amount from all the different programs. There's a lot in the news now about Vermont that wants to get a waiver from Medicare and Medicaid and everything and have one program that pays providers one particular way. That's something interesting to look at. So we have implemented a lot of things since the passage of the Affordable Care Act. And since that time, in 09, what we see in this rather busy chart is, well, the important thing is that blue line, which is the rate that we spend for each individual Medicare beneficiary, and we see that that dropped a lot with the recession, came back up a little bit, it's back up a little bit, and what we see as a projection for the future is not too much growth there relative to the general growth in the economy, which is the dotted line there. That's a much better place than we were 10 years ago when it was growing 2 or 3 times as fast as the economy. So I mentioned those pioneer ACOs. They're called pioneers because they were the first ones to do it. And these are organizations that had 15,000 lives that we could attribute to the primary practice physicians or other practitioners in that group. And it was for people that, medical groups that were already, or hospital groups that were already working with private health insurance plans with programs where they were bearing some of the risk for the outcomes with those folks. And what we found here is they did better than we predicted. So on those quality measures that we asked them to meet before they could participate in shared savings, they broke through all of them in year 1, and they did even better in year 2. And they even did well on the patient experience, which is really important to us. And so that mean quality score jumped from 71 to 85% in just that 1 year. The average performance score jumped 85% of the quality measures. That's good, because those quality things, those are things that result in your mother or your aunt who's on Medicare coming home from the hospital healthy and having some more time with their family, as opposed to spending a whole lot of time in the hospital and sometimes not coming home at all, which is not a good thing if we can avoid it. And not only did they take good care of people, but they saved money. 2 years in a row they saved money. They saved $384 million, some of which we shared with them. So each of the ACOs, on average, the Pioneer ACOs, saved $4.2 million in the second year of the program. So that's a pretty good thing. And you can see here they're in a lot of places in the country, 600,000 beneficiaries. And we are going to be extending this for some of them into 2015 and 16, as we've already done, which is great. Now, I mentioned that Secretary Sebelius had this interest in us working with states, Medicaid programs, other providers on the ground to make incentives to support advanced primary care. Primary care where they're stratifying patients, identifying the people that are at risk and bringing them in proactively, doing reminders with people, sharing data with people and with other providers that they work with. There's a lot of things around the primary care medical home that's very interesting. And one of the core ideas here is to actually make it possible to pay the providers a fee for proactively taking care of people as opposed to seeing them face-to-face all the time. And this actually worked pretty well in the 8 states where we started it in the period through 2014, and now we've extended several of those states through 2016, and 2.9 million people participated in this project, and there were savings. There was $4.2 million of net savings after the payments that we made for these services. So it proves the point that I made before, is some coordination of care, some proactive work on the part of the healthcare providers really pays off, both in the health of the beneficiaries, patients, and in the spend that we don't have to make for care that wasn't necessary or isn't of good quality. In a similar program, around 7 places we convened other payers to simply pay this simple payment to practices that can identify their patients with chronic illnesses. It's around $20 per month for those patients. And what we saw is it seems to have worked. We have an evaluation of the initial years of the program, and we clearly got back what we invested. We didn't get a lot more of what we invested. Let's think about this. If you start a business, unless you're out here in Silicon Valley, generally you're going to make an investment. Some returns are going to come in. You're not going to make your whole investment back right away. You're going to invest some more. It's going to take some time to build the business. Well, here we've gotten back our investment, so we're already good to go. We're not in the hole on this thing, and there's every reason to think that there will be further savings and further improvements, because in some of the regions they did a lot better than others, and we're endeavoring to figure out what they did, and port that kind of success over to the others. Another place where we have made an investment since the Affordable Care Act is something called the Partnership for Patients. It may be familiar to some of you, where we worked with hospital providers and other providers around the country, made some grants available, made information available to try to really attack some of the leading indicators, some of the areas in healthcare where our system simply wasn't performing the way it ought to. As a result of that, we've drastically reduced hospital-acquired conditions from 2010 to 2013, a 17% reduction, which in our calculation is probably 50,000 lives. That's somebody's mother, somebody's daughter, somebody's husband. Very important. And saved $12 billion for the taxpayers, which in these days of trillion-dollar budgets doesn't sound like a lot, but if you really think about it, it's really quite remarkable. And we see particular places where patients were experiencing harmful events in the hospital dropping rapidly. So we've got pneumonia that you get when you're in an event, not a good place to be, huge drop, 62%. Early elective deliveries, we identified that there were kids getting born when they weren't quite done. And I'm not a woman, I'm a guy, and I know when something's ready to come out of the oven, you want to do it at the right time. Same thing apparently is true with children. If you let them come when they're ready, they do better later in life. They're healthier. It's a good thing, and we focused on that. We got a tremendous result of 70% there. Central line bloodstream infections. It's not a common event, but it's a catastrophic event. 12% reduction is something to be happy about. Same thing with vein complications there with that thrombosis, that I guess like a clot, 14%, and a 7% reduction in readmissions, which is just a terrible problem. And I've lived through this with people in my family. When they, you spend the time in the hospital and the family deals with that, and you finally get the person home, and you think they're on the mend, and then everything crashes and you're back doing the same thing all over again, only now you're starting 10 steps back. It's very discouraging for the patient, for the family, and it's not very good for the Medicare program because it wastes money. So I mentioned that decline in the readmission rate. Here's a month-by-month tracking of that. I think it's really very striking, but I also know that in the best communities, the best hospital referral areas, they can get this down into the 12% range. So we are not going to stop our efforts in trying to, push this further and get better results there. Now, I want to turn to a somewhat different topic, which is this, Medicare Advantage. Up till now, primarily, I've been talking about the fee-for-service Medicare program, which is where we pay for the care of about 70% of the people on Medicare. And that's the traditional program where the government pays your bill, essentially, when you go to a doctor or other practitioner or hospital. We're your insurer, even though we use intermediaries to handle the payment. Essentially, we bear that risk. But there's another program. Once it was called Medicare Risk, once it was called Medicare Plus Choice, and now it's Medicare Advantage since the Medicare Modernization Act. And that program is a program where we pay that single capitated payment for each beneficiary each month to a private plan that that individual chose to join. It could be Humana, it could be Anthem, it could be United Healthcare. There's lots of these plans. And what's happened in that program is, first, we know across the board those plans are getting good results for those beneficiaries because they're paying attention to the very things that I talked about earlier. They're making sure that people get their immunizations. They're making sure that people know about preventive care. They're watching people with chronic diseases because that's how they get scores on HEDIS, the National Committee for Quality Assurance, the way they measure health plans, and so they pay attention to that, and that gets you those population results. But we wanted it to be better, so we developed a program where we rated those plans with 2, 3, 4, 5 stars, just like restaurants and movies. And for a while, we actually had a financial incentive to have higher stars in your plan. So for a while now, we've enjoyed almost 10% of our plans being 5-star, being just top great plans. That hasn't changed because there are clearly structural things that make a plan like that work. It's very difficult to do that outside of a closed kind of system where you have a staff-based model. But what you see in this chart is a dramatic improvement of 2-star plans becoming 3-star plans and 3-star plans becoming 4-star plans because they want to get more members. And very important to remember that for the 5-star plans, they can enroll people all year round. And that's a huge advantage to be able to sign up members when the guy next door has to close his shade and his store goes dark. I had a question, and that is, what services are considered non-visit based? It's a very good question. It's only been until recently that there are a couple of codes that can be billed by a physician practice that do not involve an encounter with the patient, either in person or telehealth. And those are codes where you're doing chronic care management, and you're looking at that patient's situation and making a call about whether they need to come in for a service or whether you need to do a reminder or whatever that might be. So that's really very, very important. And what we know over in the Medicare Advantage world, where physician groups, hospital groups that employ physicians are working on a capitation basis, they do a lot of that kind of work, because if you can just avoid one unnecessary hospital admission for a patient, especially if it's an admission to a hospital that's not in the network of your plan, that's a big cost to them. So they pay attention to that. And it's probably fair to say a lot of what we're doing in fee-for-service now are things we learned from the experience both in Medicare and outside of Medicare of private health plans that were risk-based, and learn how to manage people in a way that improves their health and doesn't waste money on things that aren't good for those people. So again, we moved in this direction of better plans. If you're in a very low-rated plan, you get a letter from the government saying maybe you ought to look at your plan. And what we see is when we prompt people like that, they are likely to switch. They pay attention, which is good. So when we talk, they're listening. Now, under the law, $10 billion was set aside over 10 years for us to create an organization called the Medicare Medicaid Innovation Center, Center for Medicare Medicaid Innovation, to be correct. And this was a huge increase in the amount of money that we spend on research. Previously, it was around $300 million a year. Now it's up to as much as $1 billion a year or more, because it can be spread over the 10 years in a lot of ways. And since they began 4 or 5 years ago, they've just gone great guns with all sorts of projects. The majority of them are in this paying provider space for a very good reason. That's what we do. We control the money that's in the Medicare Trust Fund. We apply the appropriate statute and make payments to providers, and we try to use that lever, as I mentioned it before, to affect improvements in the way care is rendered. So we have those accountable care models that we talked about. We have, I mentioned a couple of places where we're incentivizing primary care getting more sophisticated and more effective on a population basis. We have a bundled care program where we are allowing hospitals and doctors to work together, something they couldn't do before, and share in the gains of improvement. So previously, if you're a hospital, you have an orthopedic program, let's say, those doctors, whatever they do, they're going to get what Medicare Part B pays for the procedure that they perform. And the hospital is going to get the DRG. What we're doing here is we're saying, hey, how about if we give you a fixed payment for all of the acute care associated with that episode, or all the post-acute care associated with that episode, or the whole Megillah, or in Model 4, let's get really creative and pay you in advance before you even do the procedure what we think it should be, and then we'll settle it up later. Because we know from behavioral economics, when people have $1 in their pocket, they don't want to let it go. And there's a lot of interest in all these models. I may have another slide on this later, but I'm not sure. But if not, keep in mind that the core is get the physicians and the hospitals together, figuring out a way to engineer the care so that it's more effective for the patient, doesn't waste resources, and then to the extent that they can do it for less than that bundled amount, they can enjoy those savings and get a greater reimbursement for the work that they're doing, and have the satisfaction of more people, being satisfied and getting a good result on the procedures that they've had. There's also a lot of focus in the Medicaid area. We're working on reducing inappropriate psych admits for these folks when they're doing better to go to maybe a group situation in the community. We've got incentives for reducing chronic disease, for improving postnatal care. It's a very exciting area where a lot's going on, and we have a huge program focusing on that portion of our Medicare population that's also in the Medicaid program, and that's a group of people that have tremendous health needs. They have multiple chronic conditions, and they're expensive to care for. And it's okay that they're expensive to care for as long as what we're getting for the expense is good for them and good for us, but we don't think it's as good as it could have been or should have been, and that's why we have a number of initiatives both around financial alignment and managed care and around case management, still in a fee-for-service environment, to optimize the care that's given to those acutely needy people who are both Medicare eligible and on the basis of having very little income are also in Medicaid program. Many of those people are using long-term care services on the Medicaid side. So we're also doing the partnership for patients I talked about, getting information to providers, getting them to talk to each other. We're giving awards to innovators who we give their employer an award, and in return they help us go out and teach other providers ways to improve. I mentioned that there are state innovation models, and the Million Hearts Initiative has been a very effective program where we've really focused on cardiovascular disease, which still is the #1 killer for women, and I think it is for men as well. And it's really something that we can do a lot better on, so we keep shooting at that. And finally, I hope we've done a much better job in making information available to consumers, providers of care than we ever have before about what we're trying to do and how they can help us do that. That's why we're having conversations like the one that we're having tonight. So if you went on the website for the Innovation Center, if you went to cms.gov, it's pretty easy to find. You'd find this interactive map that shows you where innovation models are being tested, both at the state level in orange and individual models in the blue. And it's pretty tightly packed. We're even out in Hawaii, we're in Alaska, so we're excited about this, and there's lots of information on the website where you can look at particular programs. I mentioned how accountable care has done quite well in terms of creating savings. In the broader program, we're well spread throughout the country. Almost 8 million people under the various ACO models that we have, and just in 2015 we brought up 89 new accountable care plans. So the provider community, the healthcare industry, clearly sees that the herd is heading west, and they want to get on board and go in the direction that we're taking it, and we're excited about that. And what we're really interested in is working with the industry, with providers, with physicians, with states, and figuring out how we can get better, not dictating solutions that are created in Washington or in Baltimore, because we do not have all the answers. What we do have is a set of ears and a big old lever that we can take advantage of and really change the program. So I mentioned bundled care, how it's grown rapidly, that there are these different models, and in particular, we've got 102 people who are looking at 167 different kinds of episodes where there are these bundles. I mean, some care situations, like a joint replacement, like a heart valve replacement, lend themselves to more of a model that's built around the job that's going to be performed. Was it done correctly? Was it done successfully, and pay efficiently for it? As opposed to some medical diagnoses and admissions where it's pretty difficult to predict what might happen. That's a different kettle of fish. But as time goes by, data gets better, more and more kinds of care situations might be amenable to this bundling approach. Now, we've recently undertaken a program to build on top of what we've already done around Million Hearts to really focus on physician practices and really get into those communities and practices where, you know, maybe it's all they can do to see all the patients that are at the door that day and figure out how to deal with the different plans they have to deal with to get paid. And it's hard for them to step back and really look at making their practice thriving, more effective business. But that's the business that they're going to have to thrive in the world that I said at the outset we are evolving toward, where it's not just more service means more revenue, but it's going to be the results that we see in the population that you serve driving enhancements to revenue for practices. So that's very important. A big piece of this is a learning and action network that we recently began. It's going to create a great forum for people to work together and emphasize best practices. And we've already registered 2,800 patients, insurers, and other folks to be a part of this learning network. And the website address is on there. I'd love to see every one of you take an interest in being a part of this place where we can learn together and create this really caring community, you know, to improve the work that we're doing for folks, not just in Medicare, because we know that that's really not what it's about anymore when we're talking about quality and the improvement of care and managing costs and population health. It's really everybody. It's an artificial distinction to think that a provider or institution is going to do a better job with our beneficiaries than they are with folks across the board. So with that, that's a lot of talk. I know I can be a little bit long-winded, but I'm excited about the fact that we have launched an incredible experiment in government, industry, professionals, beneficiaries, and their representatives working together to really move the ball forward, both on quality of care that we give folks and an answer to the problem of unsustainable growth that we've seen in the past. And so with that, you have my direct information. If you have a question you'd like to field with me offline or down the road, you'll have that. But at the present time, I'd be happy to take any questions that might be online now that you'd like to ask of the whole group. You can type them into the chat, or I think we can open it up so that you can verbalize those.